Continuing with the lecture on diabetes mellitus from pathology point of view, today we will discuss the complications of diabetes mellitus. The complications could be acute complications or could be chronic complications. Acute complications, we could have diabetic ketoacidosis, we could have hyperosmolar non-ketotic hyperglycemic coma, then we could have hypoglycemia. So there are three complications: DKA, hyperosmolar non-ketotic hyperglycemic coma, and hypoglycemia. In chronic complications, in chronic complications, there could be macrovascular diseases or microvascular diseases. Okay, diseases of big vessels and small vessels. In macrovascular, the complications could be accelerated atherosclerosis among diabetes, increased risk for MI, stroke, or lower extremities ischemia. In microvascular diseases, it could be in retina, diabetic retinopathy or macular edema. In kidney, it could be nephropathy. In peripheral nerves, it could be neuropathy. So these are the acute and chronic complications of diabetes mellitus. Now let us discuss the mechanisms of chronic complications of in diabetes mellitus. We will discuss the mechanism, the functional abnormalities, and how does it clinically manifest. The first mechanism is by non-enzymatic glycosylation. Okay, the non-enzymatic glycosylation could lead to formation of advanced glycation and products, AGE, advanced glycation and products. इनका formation हो जाएगा. Then there could be release of TGF beta, VEGF, vascular endothelial growth factor, reactive oxygen species. There could be increased endothelial procoagulant activity, increased proliferation of vascular smooth muscle and extracellular matrix. These could manifest as AGE, advanced glycation end products, and these factors could lead to atherosclerosis, endothelial procoagulant activities, and proliferations of vascular smooth muscle and extracellular matrix could lead to nephropathy or neuropathy. So this is the first mechanism, enzymatic, non-enzymatic glycosylation. The next mechanism, the first one was non-enzymatic glycosylation. The second one is protein kinase C activation. Via the protein kinase C activation, it could lead to production of vascular endothelial growth factor, TGF beta, plasminogen activator inhibitor 1 by endothelium, and increased extracellular matrix synthesis. This can lead to neuropathy or retinopathy. The third mechanism in the chronic complications is the disturbance in polyol pathway. Disturbance in polyol pathway. We know that nerves, lenses, kidney or blood vessels, they have insulin dependent glucose uptake. So for glucose uptake, they require insulin. So if there is no insulin, the glucose will keep on accumulating, and this glucose via the enzyme aldose reductase will convert into sorbitol, and this sorbitol keep on accumulating. If the sorbitol accumulates in the lenses, it leads to cataract formation. Also, there is increased cellular susceptibility to reactive oxygen species, so it lead to neuropathy, retinopathy or cataract formation. So we have read the complications, acute and chronic complications, the mechanisms of chronic complication. We have read three mechanisms, that is non-enzymatic glycosylation, protein kinase C activation, and disturbance in polyol pathways. Now coming to the pathological changes in diabetes. First, we will study the changes in pancreas. In pancreas, we will see there will be decreased in the number and size of the islets. There will be leukocytic infiltration in the islets, amyloid deposits in the islets in type 2 diabetes. So number कम हो जाएगा, size कम हो जाएगा, leukocyte infiltrate कर जाएंगे, and type 2 में amyloid deposition is also seen. अगर हम इन्फेंट ऑफ अ डायबिटिक मदर देखेंगे तो उसके अंदर आइलेट्स का नंबर और साइज दोनों ज़्यादा होता है, अप रेगुलेटेड होता है. ठीक है. नेक्स्ट हम चेंजेस देखेंगे बिग वेसल्स पर, तो डायबिटिक माइक्रोवैस्कुलर डिजीजेस हम देखेंगे। तो बिग वेसल्स पे क्या क्या चेंजेस आने वाले हैं? सबसे पहला एंडोथीलियल डिसफंक्शन होगा। तो एंडोथीलियल डिसफंक्शन होने की वजह से एथेरोस्क्लेरोसिस होगा। ठीक है, तो देयर विल बी एक्सेलरेटेड एथेरोस्क्लेरोसिस ऑफ aorta and large medium sized arteries. Also there will be hyaline arteriosclerosis, hyaline deposition. So there are three changes. One is endothelial dysfunction, accelerated atherosclerosis, and hyaline arteriosclerosis, which are seen in macrovascular disease of diabetes. Now looking at the small vessels. So in these small vessels, diabetic microangiopathy, the finding is diffuse thickening of basement membrane in the capillaries. तो कैपिलरीज की बेसमेंट मेम्ब्रेन में डिफ्यूज थिकनिंग होगी, एंड द माइक्रोएंजियोपैथी, द माइक्रोवैस्कुलर डिजीज इज रिस्पॉन्सिबल फॉर नेफ्रोपैथी, रेटिनोपैथी और न्यूरोपैथी. So we have seen in macrovascular disease there is endothelial dysfunction, accelerated atherosclerosis and hyaline arteriosclerosis. While in microvascular disease there is diffuse thickening of basement membrane in the capillaries. Now coming to a very important topic, diabetic nephropathy. Herein we will see the changes at the glomerulus level, then at the vascular level, then at other levels as well. So in the glomerular lesion, the glomerular lesion could be capillary basement membrane thickening. One, there could be diffuse mesenteric sclerosis, which is the most common finding. Then the glomerulosclerosis could be diffuse glomerulosclerosis or could be nodular glomerulosclerosis. The nodular glomerulosclerosis is also known as Kimmelstein-Wilson lesion. Kimmelstein-Wilson lesion. While diffuse glomerulosclerosis could be represented as fibrin cap or capsular drop. The fibrin cap is the hyaline membrane in the capillary loop, while the capsular drop is the hyaline membrane which is adherent to the Bowman's capsule. Then there is Armani-Epstein lesion, which is hyaline membrane in the tubules. So it's very easy to remember. अगर hyaline membrane tubules के अंदर है तो उसे Armani-Epstein lesion कहेंगे. अगर hyaline membrane Bowman's capsule से चिपकी हुई है तो कैप्सूल से चिपकी हुई है तो इसे कैप्सूलर ड्रॉप कहेंगे. अगर hyaline membrane कैपिलरी की लूप में है तो उसे फाइब्रिन कैप कहेंगे. Okay. Okay, if I show this in a diagrammatic representation, if this is the glomerulus, and this is the glomerulus, and this is the glomerulus, and if we see deposits here or some deposits here, hyaline membrane deposits here, if we see it here, then it is adherent to the Bowman's capsule. So these are known as capsular drops. If hyaline membrane deposits are seen here, then these are known as fibrin caps. So if this sort of picture is here, and you can see in the case of there is any arteriole, there will be hyaline thickening of the arterioles. And in the case of mesenterium, if you see the mesenterium, here there will be diffuse hyaline deposits. There will be mesenterial sclerosis, which is very common finding. In case of diffuse glomerulosclerosis, we will see capsular drop and fibrin caps. But in case of Kimmelstein-Wilson lesion, we will see some nodular deposits. These are nodular hyaline deposit in the mesenterium, okay, which is known as Kimmelstein-Wilson lesion. So this is the finding in the glomerular lesion. The other changes are in the renal vasculature. We can see arteriosclerosis, which will involve both the efferent arterioles as well as the efferent arteriole. Then there could be pyelonephritis, which includes necrotizing papillitis, that is papillary necrosis, which will start in the interstitial tissue and it will spread to the tubules. This is called as papillary necrosis. So these are the finding in the diabetic nephropathy: glomerular lesions, vascular lesions, and pyelonephritis. In glomerular lesion, there is capillary basal membrane thickening, mesangial sclerosis, diffuse glomerulosclerosis, fibrin cap capsular drop, or nodular glomerulosclerosis, Kimmelston-Wilson lesion, or Armani-Epstein reaction, which is highly membrane deposits in the tubule. Now, in brief, you will see the diabetic ocular complication, which could be cataract. Diabetic induced hyperglycemia can lead to cataract. Could be glaucoma, which can lead to optic nerve damage. Could be retinal vasculopathy, which could be proliferative vasculopathy or non-proliferative vasculopathy. So these are the ocular complications. Then in very brief, the diabetic neuropathy. The neuropathy could involve the central nerves as well as peripheral nerves. The distal symmetrical polyneuropathy is the most common pattern which is seen. Autonomic nervous system is also involved. So these are all about the complications of the diabetes mellitus. It could be acute complication, it could be chronic complications. Acute complications we read is diabetic ketoacidosis, hyperosmolar non-ketotic hyperglycemic coma, hypoglycemia. Then in chronic we said macrovascular हो सकती है, microvascular हो सकती है. Macrovascular में atherosclerosis, MI, stroke, lower ischemic extremity ischemia. Microvascular में diabetic retinopathy, nephropathy, neuropathy. These could be there. Then the mechanism could be non-enzymatic glycosylation, could be protein kinase C activation, could be the polyol pathways. Then we have seen the different changes, pathological changes in diabetes, diabetic nephropathy, ocular complications, and diabetic neuropathy. So herein we finished with the diabetes. This is all about the diabetes. Thank you so much.